Welcome to the Deep Dive, the show where we take really complex clinical sources and break them down, aiming for that mastery-level understanding.
Exactly. And today we're tackling something that needs incredible precision. Injuries to the female genital and intestinal tracts. It's an area where you absolutely need a deep grasp of the anatomy and the mechanisms.
Yeah, the sources we're drawing on are very clinical, very detailed, covering everything from how these injuries happen to diagnosis and the specifics of surgical management.
And our mission here is to really unpack all that detail so you, the listener, come away with, well, genuine mastery, not just ticking boxes, but really understanding it.
So, setting the stage. What's the main context for these injuries? Is it mostly accidents, external trauma?
That's the first crucial point. External trauma is, thankfully, quite rare. The overwhelming majority, the vast majority, really, of the serious injuries we'll discuss today are obstetrical. They happen during childbirth.
Okay, so birth-related. And the stakes are high.
Extremely high. Missing these injuries or not repairing them correctly right away can lead to catastrophic outcomes. We're talking severe bleeding, infection, chronic pain from scarring, and really devastating functional problems like incontinence, both urinary and fecal. So immediate recognition and repair are paramount.
Got it. So let's start there with the spectrum of obstetric trauma.
Right. Even a completely normal delivery leaves some permanent changes. It's important to understand that baseline.
Like what sort of changes?
Well, take the cervix. Before birth, the external os, the opening, is perfectly round. During delivery, the muscle fibers tear laterally on each side.
Ah, so it's no longer circular afterwards.
Exactly. That's what permanently creates the anterior and posterior lips of the cervix that we see clinically. And similarly, the hymen stretches and tears, leaving behind those little tags of skin called the carunculae myrtiformes. That's normal.
Okay, so that's the baseline. Let's move into actual trauma then, starting with the vagina. What causes tears there?
Vaginal tears, especially isolated ones high up in the vault, often happen during instrumental deliveries, forceps or vacuum or, manipulations during delivery. Basically, the friction or force just exceeds what the tissue can handle.
And managing those, is it just straightforward suturing?
Often, yes, prompt repair is needed to stop bleeding. But the vagina's tissues are quite lax, so bleeding can be hidden. Interestingly, our sources mention sometimes, especially with diffuse tears, they might use temporary packing instead of immediate stitches.
Packing, how does that work?
They use sterile roller gauze soaked in an antiseptic like glycerin, acroflavine, or betadine. It acts like a compress to stop the bleeding temporarily and provide some antiseptic effect. They usually remove it after about 24 hours once things have settled for a definitive repair.
Okay, moving up then to the cervix. What causes cervical tears?
These usually result from intense pressure. Think strong uterine contractions pushing against a cervix that isn't fully dilated yet, or maybe a difficult presentation like an occiput posterior position.
Occiput posterior. That's when the baby's head is facing upwards, right?
Exactly. Instead of the smallest diameter presenting, a larger diameter forces its way through, which puts much more stress on the cervix. Cervical dystocia, where the cervix just doesn't dilate properly, also increases the risk significantly.
And the key sign that makes you suspect a cervical tear is kind of counterintuitive, isn't it?
It is. You see excessive vaginal bleeding, but when you feel the uterus, it's firm, well contracted. That's the clue.
Why is that a clue?
Because a well-contracted uterus should clamp down on its own blood vessels and stop uterine bleeding. If the uterus is hard but bleeding continues heavily, the source must be lower down a tear in the cervix or vagina where vessels are torn open.
So you need to look closely.
Absolutely. Diagnosis requires a thorough speculum exam. You need to visualize the entire cervix, rotating it carefully with ring forceps to inspect every part before you even think about repairing it.
And if a cervical tear is really severe, it can lead to something called colporexis.
Yes, colporhexis. That's a rupture of the vaginal vault, the very top of the vagina. It's a major life-threatening emergency.
Does it happen on its own?
It can, but it often occurs along with a deep cervical tear. If the rupture extends laterally into the sides of the vaginal vault, blood can track upwards into the pelvic spaces, leading potentially to a rapidly forming broad ligament hematoma. This isn't a small bruise. It's a large collection of blood that often needs an immediate laparotomy, opening the abdomen to find and control the bleeding vessels.
Wow. And repairing the vault itself sounds risky too.
Extremely risky during the repair. The uterine vessels and, crucially, the ureters, the tubes from the kidneys to the bladder, run right next to the lateral vaginal fornices. Surgeons have to be incredibly careful not to accidentally tie off or damage these vital structures while closing the tear.
Okay, so culparexis is bad. But the absolute worst obstetric injury, the one clinicians really fear.
That would be uterine rupture. It's the most dreaded complication, carries incredibly high maternal and fetal mortality rates.
What usually causes it?
It's seen most often in women who've had previous births, often following a neglected, obstructed labor. Basically, the uterus keeps contracting powerfully against an obstruction it can't overcome, like a cervix that won't dilate, and the lower segment eventually just tears.
Any other major causes?
Misuse of oxytocic drugs like syntocinon used to strengthen contractions. If given improperly, they can cause hyperstimulation, contractions that are too strong or too frequent, overwhelming the uterine muscle, and of course dehiscence, or opening up of a previous cesarean section scar.
So a previous C-section is a major risk factor in subsequent labors.
A huge risk factor. The scar tissue might not hold up under the stress of full labor. Our sources really highlight the tragic situations, like in parts of India, where home births without access to diagnosis or intervention for obstructed labor lead to devastating rates of uterine rupture. It just underscores how vital skilled birth attendants are.
Shifting gears slightly, what about uterine perforation outside of pregnancy, like during surgical procedures?
Yes, that happens too, usually iatrogenically, meaning caused by a medical procedure. Most commonly during things like dilation and curettage, DNC, or more complex hysteroscopic surgeries.
Like which ones?
Things like transcervical resection of the endometrium, TCRE to remove the uterine lining, or dividing a uterine septum. The risk of perforation goes way up if the uterine wall is unusually soft, maybe due to early pregnancy or malignancy, or if it's very thin and atrophic, like in postmenopausal women. An instrument can just push right through.
With potential damage to...
Bladder, bowel, major blood vessels outside the uterus. It's a serious complication.
Okay, let's focus lower down now on the perineum, which really bears the brunt of delivery. Managing tears there immediately seems critical.
It's absolutely fundamental postpartum care. After any vaginal delivery, especially if it involved instruments or significant bleeding, you must do a thorough, systematic inspection of the perineum and lower genital tract. And you need good light.
Why is good light so important?
Because you can easily miss a small bleeder hiding in a fold or underestimate the depth of a tear. Missing something can lead to a hematoma or worse, long-term problems like incontinence or prolapse.
So do all tears need stitching?
Tiny, superficial ones on the fourchette that aren't bleeding might heal on their own, but pretty much everything else needs prompt surgical repair. And ideally, this should happen in an operating theater with an assistant, proper anesthesia, a controlled environment for meticulous work.
Right. This brings us to the grading system for perineal tears.
Hmm.
First, second, third, fourth degree. This seems really important for understanding severity and prognosis.
It's the standard language, absolutely vital. Let's break it down. First degree, very superficial, just the skin of the fourchette or a bit of vaginal mucosa, usually minor.
Okay.
Second degree. Now we're getting into muscle. The tear goes through the muscles of the perineal body. And here's the crucial part: if it also involves the fibers of the levator ani muscle.
The main pelvic floor muscles.
Exactly, the supportive sling. If those tears, the whole pelvic floor integrity is weakened. This is what predisposes women to prolapse, sometimes years later.
Okay, so second degree can have long-term consequences. What's third?
Third degree. The tear extends further back and involves the external anal sphincter muscle, the muscle you consciously squeeze to hold things in. So continence is now definitely at risk.
And fourth?
Fourth degree. This is the most severe. The external sphincter is completely torn and the tear goes right through into the anal mucosa, the lining of the anal canal or rectum. There's a direct connection between the bowel and the vagina.
That sounds like an emergency.
It is a true surgical emergency. Needs immediate, expert repair to prevent fecal incontinence and fistula formation.
That detail about the second degree tear potentially involving the levator ani, it really highlights how even seemingly moderate tears can set someone up for problems down the road, like prolapse.
Precisely. It's often the unseen damage, the subclinical weakness, that leads to functional decline later on.
Now, most tears go front to back, right? But you mentioned a rare central tear.
Yes, very unusual. Instead of tearing towards the anus, the baby's head actually pushes through the posterior vaginal wall and the perineal body, emerging through the skin in front of the intact anal sphincter.
How does that happen?
It's almost exclusively seen when the woman has a contracted pelvic outlet. The normal path is blocked, so the head finds this alternative, very traumatic route.
Okay, let's revisit something you mentioned earlier, occult injuries. Injuries you can't see. The statistic here is pretty shocking.
It really is. This is one of the most critical takeaways from our sources. Occult sphincter injury, meaning damage detectable only by specialized tests like anoendoscopy, occurs in up to 35% of first-time mothers. Prima pari.
35%. Even if the perineum looks completely intact after delivery.
Even then, it fundamentally changes how we should think about postpartum assessment. If potentially 1 in 3 first-time moms has hidden sphincter damage, we need to be much more proactive about follow-up and maybe screening, not just waiting for symptoms like incontinence to appear years later.
Given that high risk, both visible and hidden, what are the specific factors that make a tear more likely?
The sources group them into categories based on the forces involved. First, overstretching. This is the big one.
Caused by?
Big baby, long, difficult labor or dystocia, a persistent occipito-posterior position, any instrumental delivery like forceps or vacuum, delivering the aftercoming head in a breech birth.
Makes sense. What else?
Second, rapid stretching. When the tissues don't have time to adapt, this happens in precipitate, very fast labor or, again, sometimes with breech delivery.
And the third category?
Third is a rigid perineum, tissues that just aren't very elastic. You see this more in older first-time mothers, women with significant vulval edema, or if they're scarring from previous tears or surgery.
So knowing these risks, what can be done to prevent tears, or at least minimize them?
Prevention focuses on controlling the delivery, supporting the perineum as the head crowns, allowing gradual stretching, and using an episiotomy, a surgical cut, if a tear seems inevitable or very likely.
When is episiotomy specifically recommended?
Definitely recommended during instrumental deliveries and assisted breech deliveries to provide more room and guide the potential tear.
But there's a caveat about future pregnancies, isn't there? For women who've had severe tears repaired.
Yes, a crucial point. For women who've had a successful repair of a 3rd or 4th degree tear, or who already have significant issues like prolapse or urinary fistulas, an elective cesarean section for future births might be the safest option to protect the repaired or vulnerable tissues.
Okay, let's get into the repair of those severe tears 3rd and 4th degree. You said it's an emergency. What are the key steps?
It absolutely has to be done promptly, under anesthesia, in theater. Good light, good assistance, control the bleeding first. Then the repair follows a very specific sequence, layer by layer.
Take us through that sequence. Where do you start?
You start deep, with the dirtiest layer, the rectal wall or anal canal lining. This gets repaired first using fine absorbable sutures like Vicryl 30. Critically, you often use a few Lembert sutures. These turn the edges inwards into the bowel lumen, burying the suture line to reduce the risk of fistula.
Okay, rectum first, then what?
Then you move outwards, reconstructing the perineal body muscles. This includes finding and bringing together those important levator antifibers if they were involved. You need to restore the anatomy of that muscular support.
And finally?
Finally, the external sphincter animuscle. You have to carefully find the retracted ends of the torn muscle they often pull back and bring them together accurately with at least 2 strong sutures, usually Vicryl. Good apposition, no tension. Only then do you close the vaginal wall and the perineal skin.
That sequence makes sense. Deep to superficial, clean last.
Yeah.
But you mentioned there's some debate about how exactly to repair the sphincter muscle itself.
Yes, this is where surgical technique gets interesting. The traditional method is end-to-end repair, just sewing the 2 cut ends directly together.
Okay.
But many surgeons now advocate for an overlap technique. They dissect the ends slightly, overlap one over the other, and suture them together like that.
Why the overlap? What's the thinking?
The argument is that it creates a stronger, more robust repair, potentially leading to better long-term sphincter function and continence. Imagine splicing a rope versus just taping the ends.
But is the evidence clear on that?
That's the thing. Our sources say it's still controversial. Some studies show a benefit to overlap. Others suggest a meticulous end-to-end repair works just as well. The absolute key, regardless of technique, seems to be accurate anatomical identification and tension-free closure.
Let's shift now to the patient who presents much later, maybe years later, with an old, long-standing, complete perineal tear. This is basically a failed or missed initial repair, right? Exactly. It's a chronic, unrepaired 3rd or 4th degree tear. The appearance is quite characteristic.
What do you see? You see the red, moist mucous membrane of the anal canal or rectum directly fused with the posterior vaginal wall. There's no perineal body in between. And out to the sides, you can often see or feel distinct dimples in the skin where the severed ends of the external sphincter muscle retracted long ago. It severely impacts continence and sexual function.
But there's a fascinating paradox here regarding prolapse, isn't there?
Yeah.
You'd expect these women to have terrible prolapse, but often they don't.
It's a remarkable compensatory mechanism because the main voluntary supports, the perineal body and external sphincter, are gone. The patient has to constantly, almost subconsciously, contract their deeper levator ani muscles just to maintain any degree of continence, to try and hold things in.
So they're constantly working those muscles.
Constantly. And over time, this chronic high level of contraction makes the levator ani muscles incredibly strong and toned hypertrophied, really. This acquired hypertonicity effectively braces the pelvic floor from within, preventing the uterus and vagina from prolapsing downwards, even though the perineum itself is deficient. It's quite amazing.
That's incredible. So when is the best time to surgically repair these old tears?
The optimal window is generally 3 to 6 months after the initial injury or delivery.
Why that time frame?
If you operate too early, say within the first few weeks or months, the tissues are still inflamed, maybe a bit friable, and the repair is more likely to fail. But if you wait too long, beyond 6 months or a year, dense scar tissue forms, making the dissection much harder and potentially compromising the outcome.
And the preparation for surgery seems intense. Bowel prep is key.
Absolutely crucial. You're operating right next to the rectum. The patient needs hospitalization beforehand for thorough bowel emptying using laxatives and enemas, a low-residue diet, and good vaginal disinfection. Most importantly, they need bowel sterilization with antibiotics like neomycin or ampicillin for several days before surgery to minimize the risk of infection if the bowel is inadvertently entered or if there's microscopic contamination.
Surgically, what's the main challenge compared to repairing a fresh tear?
The biggest challenge is dealing with the scar tissue. The absolute key technical step is mobilization. You have to carefully dissect the rectum completely free from the surrounding scar tissue, freeing it up so that when you close the defect, the edges come together easily without any tension.
And the repair itself.
Once it's fully mobilized, you repair the rectal defect, making sure to invert the edges into the bowel lumen. Then, critically, you change gloves and instruments before moving on to repair the sphincter muscle and levator ani layers, finishing with the vaginal and perineal skin closure. Mobilization without tension is paramount.
Okay, we've thoroughly covered obstetric injuries. Let's move on to other causes of trauma to the genital tract, starting with injuries related to coitus. These seem to vary a lot in severity.
They really do. The typical first intercourse, or defloration, involves hymenal tearing, which usually causes only minor self-limiting bleeding. But sometimes that tear can extend, especially forwards into the vestibule area near the clitoris, which is very vascular.
And that can cause significant bleeding.
Yes, occasionally it can cause quite severe hemorrhage that needs medical attention, maybe sutures under anesthesia, sometimes even a blood transfusion if it's really brisk.
When does coital trauma become much more serious, causing deep lacerations?
It tends to happen when there's significant force involved or when the tissues are particularly vulnerable. So you see severe lacerations sometimes with sexual assault or rape, especially in very young girls whose tissues aren't fully developed, or in postmenopausal women with significant vaginal atrophy due to low estrogen. Their tissues are thin, dry, and tear easily. Malformations, like a transverse vaginal septum, can also predispose to tearing.
What kind of damage can occur?
It can be quite dramatic. Deep longitudinal tears, often in the anterior vaginal wall. Or, more catastrophically, a tear right through the posterior vaginal wall, opening directly into the peritoneal cavity. And in the worst cases, the bladder or rectum can be involved too.
There's also a specific warning related to coitus after surgery, isn't there?
Yes, this is a really important clinical point. Resuming intercourse too soon after vaginal surgery, especially after a total hysterectomy where the top of the vagina, the vault, has been stitched closed, is dangerous. Why? Because the vault closure is still healing and vulnerable. Forceful intercourse can disrupt the suture line, causing the vault to rupture. This can lead to the horrifying complication of bowel, small bowel, large bowel, or omentum prolapsing directly out through the vagina.
That sounds like another emergency.
An absolute emergency. Requires immediate surgical intervention, usually laparotomy, to retrieve the bowel, check for damage, and repair the vaginal vault securely. It can lead to shock and peritonitis quickly.
The sources also mention something quite surprising, spontaneous vaginal rupture in older women.
Yes. It's rare, but it happens, usually in the upper posterior third of the vagina in elderly women with significant atrophy. It's often triggered by a sudden, sharp increase in intra-abdominal pressure, like a violent cough or severe straining. The thin, atrophic tissue just gives way.
Okay, moving on to direct trauma-like falls. These often cause hematomas.
Yes, falling astride something, a gate, a chair armrest, a bicycle bar, is a common mechanism for vulval injury. It might just cause bruising, but because the labia majora have very loose tissue and the area around the clitoris and vaginal opening is rich in erectile vascular tissue, if a blood vessel breaks, a large hematoma can form very quickly.
And hematomas can also happen after delivery, right, as an iatrogenic issue.
Very commonly. Probably the most common cause of a vulval hematoma is inadequate hemostasis, not stopping the bleeding properly when suturing an episiotomy or a perineal tear. A small vessel keeps bleeding into the tissues.
What does it look like, and how do you manage it?
It presents as a tense, painful, tender, often bluish-black swelling in the vulva or perineum. Small ones might resolve with conservative measures, bed rest, ice packs initially, then maybe warm sitz baths, magnesium sulfate compresses. But large or rapidly expanding hematomas need surgical intervention.
Which involves?
Incision under anesthesia, complete evacuation of all the blood clots, careful search for the specific bleeding vessel or vessels, and ligating them securely. Sometimes the cavity needs packing for 24 hours or a drain inserted before closing the skin.
And deeper inside, there are pelvic hematomas too.
Yes, these are more serious. They're broadly divided based on their relationship to the levator ani muscles. Infralevator hematomas are essentially those vulval or perineal ones we just discussed below the pelvic floor. Supralevator hematomas form above the pelvic floor, usually within the broad ligament.
What causes those?
These typically result from deeper injuries, extensive cervical tears that involve the uterine artery branches, or sometimes following uterine rupture.
How do you manage a large supralevator or broad ligament hematoma? It sounds like it could compress things.
Small, stable ones might be watched closely with antibiotics, as they often resorb, but a large, expanding one is a surgical emergency, often presenting with signs of shock, low blood pressure, fast heart rate. If you can't control the bleeding vaginally, you need a laparotomy.
What do you do during the laparotomy?
You might try to find and ligate the specific bleeding vessel. If that's impossible, you might have to pack the broad ligament space tightly for 24-48 hours to tamponade the bleeding. More drastic measures could include ligating the internal iliac artery on that side to reduce blood flow, or uterine artery embolization by interventional radiology if available. If it's associated with uterine rupture, a hysterectomy is often necessary.
Lastly, in this section on non-obstetric trauma, we need to touch upon female genital mutilation, or FGM.
Yes, FGM is a harmful traditional practice unfortunately prevalent in various parts of Africa, Asia, and the Middle East. It involves partial or total removal of the external female genitalia for non-medical reasons. The WHO classifies it into 4 main types based on severity.
Can you outline those types?
Type 1 is removal of the clitoral hood, with or without removal of the clitoris itself. Type 2 involves removing the clitoris, plus partial or total removal of the labia minora. Type 3 is the most severe, often called infibulation. It involves removing the clitoris and labia minora and then stitching the remaining labia majora together, leaving only a tiny opening for urine and menses. Type 4 is a catch-all for other harmful procedures like pricking, piercing, cauterizing, scraping, etc.
The consequences are severe both immediately and long-term.
Definitely. Immediate complications include severe pain, bleeding, infection, urine retention. Long-term consequences include chronic pain, especially from nerve damage, painful intercourse, dyspareunia, or inability to have intercourse, apriunia, particularly after type 3. There's also increased risk of HIV and tetanus transmission from unsterile procedures. And critically, FGM, especially type 3, causes major problems during childbirth, often leading to obstructed labor, severe tearing, and frequently requiring C-section or a surgical procedure called deinfibulation beforehand.
Right. Let's move on to injuries from foreign objects, instruments, or chemicals. Starting with foreign bodies in the vagina. There seem to be 2 distinct scenarios here.
Yes, broadly speaking. First, you have the sort of bizarre foreign bodies. These are things you wouldn't expect. Safety pins, bottle caps, small toys, pencils, even things like jam jars. You tend to see these in young children or sometimes in patients with intellectual disabilities.
And the main sign is?
The classic sign is a persistent, foul-smelling, often blood-stained vaginal discharge that doesn't respond to usual treatments for vaginitis. That should always raise suspicion.
Okay, that's one type. What's the other?
The second type involves therapeutic foreign bodies that have been forgotten or neglected. The most common example by far is a ring pessary used for prolapse.
How does a forgotten pessary cause problems?
If left in place for months or years, especially without regular cleaning and removal, they can become encrusted with mineral deposits. These rough deposits then rub against the vaginal wall, causing chronic irritation, deep ulceration, especially in the posterior fornix. And in very rare long-standing cases, this chronic irritation has even been linked to the development of vaginal cancer.
Any other examples?
Forgotten tampons are common, leading to severe infection and discharge. Neglected contraceptive diaphragms or cervical caps can do the same.
What about foreign bodies inside the uterus?
These are almost always related to contraception specifically, neglected or forgotten intrauterine contraceptive devices, IUDs, like the copper T.
What complications can they cause?
If left too long or if they migrate, they can cause chronic inflammation, ulceration of the uterine lining, endometrium, leading to heavy or irregular bleeding, menorrhagia. More seriously, they can act as a focus for ascending infection, potentially leading to pelvic inflammatory disease, PID, pelvic abscesses, or tubo-ovarian masses.
And if an IUD is suspected of having perforated the uterine wall, what's the protocol?
If there's any suspicion of perforation, maybe it can't be seen on ultrasound or hysteroscopy, then surgical exploration, usually laparoscopy or sometimes laparotomy, is mandatory.
Why? What are you looking for?
The main concern is whether the IUD has migrated into the peritoneal cavity and potentially injured or embedded itself in adjacent organs, especially the bowel or bladder. Leaving a perforated IUD floating around risks delayed bowel perforation or adhesion formation.
What about treatment? Just remove the IUD.
Removal is the goal, sometimes needing hysteroscopy or laparoscopy. If there's severe infection, like a tubo-ovarian abscess, extensive surgery might be needed, sometimes even hysterectomy and removal of tubes and ovaries, although thankfully powerful antibiotics make that less common now than it used to be.
Let's talk about instrumental damage, maybe from unsafe abortion attempts.
Yes, sadly, attempts at illegal or unskilled abortion using inappropriate instruments, sounds, sticks, knitting needles can cause devastating trauma. Perforation of the uterus is common, but also direct injury to the bladder, rectum, or bowel through the vaginal wall or uterus.
And damage can happen during legitimate procedures, too.
It can. For example, overly forceful or repeated dilation of the cervix, perhaps during D&C, can damage the internal os, leading to cervical incompetence and subsequent mid-trimester pregnancy losses.
What about procedures on the cervix itself, like conization?
Procedures like conization, removing a cone of tissue for biopsy, or older operations like cervical amputation, sometimes part of prolapse surgery, can lead to cervical stenosis, a significant narrowing or even complete closure of the cervical canal due to scarring.
And the consequence of stenosis.
If the canal is blocked, menstrual blood can't escape. This leads to hematometra, a uterus filled with trapped blood, or if it gets infected, pyometra. This causes pain and, obviously, infertility.
Finally, in this section, chemical and thermal burns. These sound particularly nasty due to scarring.
They can be. Historically, chemical burns were often caused by people using strong corrosive substances, things like Lysol, potassium permanganate, inserted into the vagina in an attempt to induce abortion. These chemicals cause widespread destruction of the vaginal lining.
And the healing process is the main problem.
Exactly. As the extensive burns heal, massive scar tissue and adhesions form. This fibrosis can completely obliterate the vaginal canal, a condition called vaginal atresia or stenosis.
Leading
to inability to have intercourse, aporunia, and if the uterus is still functioning, trapping of menstrual flow causing hematometra or pyometra. The only treatment is often complex plastic surgery to reconstruct a functional vagina.
What about thermal burns?
These can happen from things like excessively hot douches, although that's rare now. More commonly, it was related to older methods of cervical treatment using heat cautery or diathermy. Modern techniques like cryosurgery and laser are generally safer, but still carry some risk of thermal injury if not used carefully. Laser treatment for vaginal lesions or cancer in situ can also cause burns.
And radiation.
Radiation therapy, especially brachytherapy, where radioactive sources are placed directly in or near the cervix to treat cervical cancer, inevitably causes some degree of radiation burn and subsequent fibrosis to the vaginal vault. This often leads to significant shortening and narrowing, sometimes complete obliteration, of the upper vagina.
Okay, we've focused a lot on the genital tract, but the bowel, especially the rectum and anal canal, is right there anatomically. So injury during pelvic procedures is a constant risk, isn't it?
Absolutely. The close proximity makes the bowel vulnerable during vaginal delivery, during vaginal surgery, especially posterior repairs, and also during abdominal or laparoscopic gynecological operations.
How common is bowel injury during gynae surgery?
Thankfully, it's relatively rare. The quoted incidence is usually somewhere between 0.3% and 0.8%. But when it happens, especially if it's missed, the consequences can be severe peritonitis sepsis.
How do these injuries typically happen during surgery? What are the mechanisms?
There are two main ways. First, mechanical injury during entry into the abdomen or pelvis. This is often with the varus needle or trocars used in laparoscopy. The risk is much higher in patients who are obese, have had previous surgery causing adhesions, or have conditions like severe endometriosis or PID, where the bowel might be stuck to the pelvic organs.
Second way.
Second is thermal injury from energy devices, cautery, or laser used during surgery, particularly laparoscopy or hysteroscopy. The heat can inadvertently damage adjacent bowel that might be stuck nearby or just too close to the surgical field.
And you mentioned thermal injuries can be tricky to diagnose.
Yes, this is a crucial point for clinicians. Unlike a direct cut or tear, a thermal burn might not perforate the bowel immediately. The heat devitalizes the tissue, and the necrosis, the tissue death, can take several days to develop fully.
So the patient might seem fine initially.
Exactly. They might be discharged home only to present 5 to 7 days later with symptoms of peritonitis or an ileus because the weakened bowel wall has finally given way. It's a delayed presentation that requires a high index of suspicion.
If a bowel injury is recognized, how is it treated? Does it depend on the size and location?
It does. A very small injury, say less than 5 millimeters, in the small bowel might be repairable with a simple purse string suture or closing it transversely. But larger injuries, or those involving the blood supply, usually require formal resection of the damaged segment and an end-to-end anastomosis, joining the healthy ends back together.
What about injuries to the large bowel or rectum?
Those are generally considered higher risk for leakage and infection after primary repair, especially if the bowel wasn't prepped. So injuries to the colon or upper mid-rectum often require not just repair, but also a proximal colostomy, bringing a loop of bowel out onto the abdominal wall to divert the fecal stream and allow the repair site to heal without contamination.
So prevention is obviously key. What are the main strategies?
Good obstetric management is #1 for preventing birth injuries. In surgery, especially high-risk cases like endometriosis or PID with adhesions, meticulous, sharp dissection is vital, carefully peeling bowel away rather than blunt tearing. And extreme care and awareness of surrounding structures are needed when using energy devices like cautery or laser during laparoscopy.
Okay. Now let's do a really deep dive into perhaps the most functionally devastating long-term consequence: facial incontinence.
Right. Fecal incontinence is the involuntary loss of bowel control.
Yeah.
It could be just flatus or liquid stool or even solid stool. It affects women much more often than men, with estimates around 0.5% to maybe 2% after vaginal delivery, although the true figure, including minor leakage, might be higher.
To really understand incontinence, we need to understand the anatomy of continence, right? What keeps us continent normally?
There are 3 key structures working together. 1, the internal anal sphincter. This is smooth muscle, involuntary, under autonomic nerve control. It provides most of the resting tone, keeping the anal canal closed at rest. About 80% of resting pressure comes from this.
Okay, the background tone.
The external anal sphincter. This is striated muscle, like your bicep, under voluntary control via the pudendal nerve from spinal segments S2, S4. This is the muscle you consciously squeeze when you feel the urge to defecate or need to hold on.
The conscious control muscle.
3, the puborectalis muscle. This is actually part of the larger levator ani muscle complex. It forms a sling around the rectum where it joins the anal canal. Its contraction pulls the rectum forward, creating a sharp rectoanal angle, typically between 60 and 130 degrees.
And why is that angle important?
That angle acts like a flap valve or a kink in a hose. It mechanically prevents stool from descending from the rectum into the sensitive anal canal until you consciously relax the muscle during defecation. It's crucial for maintaining continence, especially for solid stool.
So damage to any of the muscles directly or the nerves controlling them can lead to incontinence.
Precisely. And the main cause of that damage, again, is trauma during childbirth.
Like what specific aspects of childbirth?
Prolonged second stage of labor can stretch the pudendal nerves or the levator ani muscles, causing temporary or sometimes permanent damage. Difficult forceps deliveries, delivering a large baby, a persistent occipito-posterior position, a very rigid perineum all increase the risk of direct muscle tearing or nerve injury. And remember that occult injury statistic, up to 35% of first-time moms have some internal sphincter damage, even if the perineum looks fine.
We also need to revisit episiotomy here. The type matters, doesn't it?
It really does. This is a critical insight from the sources. While often done with good intentions, a midline episiotomy, cutting straight down towards the anus, actually carries a higher risk of extending into and damaging the anal sphincter complex compared to a mediolateral episiotomy, cutting diagonally outwards.
Why is that?
Because the midline cut follows the natural line of least resistance straight towards the sphincter. If the tear extends, that's where it's going to go. The mediolateral cut angles away from the sphincter, theoretically offering more protection.
So if someone develops incontinence, how do you investigate the cause?
You start with a careful history and physical exam, including a digital rectal exam, then specialized tests. Proctoscopy or sigmoidoscopy look inside the rectum. Anal manometry measures the pressures generated by the internal and external sphincters, both at rest and during squeeze effort. Normal resting pressure is around 45-100 millimeters of mercury.
What about imaging or nerve tests?
Historically, electromyography, EMG, was used to assess nerve damage to the external sphincter or puborectalis, but the sources emphasize that endoanal ultrasound, an ultrasound probe placed in the anal canal, is now generally preferred. It gives excellent high-resolution images of the sphincter muscles themselves, clearly showing any defects or thinning. It's often replaced EMG for diagnosing structural damage.
And once you have a diagnosis, what are the treatment options?
It's a spectrum. Medical management includes dietary changes, like high-fiber diets to bulk the stool, and medications like loperamide or codeine phosphate, which can increase sphincter tone and slow transit. Physiotherapy is huge pelvic floor muscle training, often with biofeedback, to help patients learn to isolate and strengthen the correct muscles, external sphincter and puborectalis.
What about more advanced options?
Sacral nerve stimulation, SNS, implanting a device like a pacemaker that stimulates the nerves controlling the sphincters can be effective for some types of incontinence. Surgery is usually reserved for repairing significant structural defects like large sphincter tears or rectovaginal fistulas, or addressing associated prolapse. And again, if a woman has successful surgical repair, future deliveries should ideally be via elective C-section.
Let's cover that final related topic, rectovaginal fistula. An abnormal tunnel between the rectum and vagina. What usually causes these?
Like sphincter injuries, the most common cause is obstetric trauma. Specifically, an improperly repaired fourth-degree tear that breaks down, or the breakdown of a repair of an old tear. Sometimes, unfortunately, it can be iatrogenic. The rectum is accidentally opened during vaginal surgery, like a posterior repair, especially in elderly patients with thin tissues.
Are there non-obstetric causes too?
Yes, quite a few. Infections like tuberculosis, noted as common in places like India, certain STIs like lymphogranuloma venereum, inflammatory bowel disease like Crohn's disease, and importantly, cancer, advanced cervical or vaginal cancer eroding into the rectum, or rectal cancer eroding into the vagina. Radiation therapy for pelvic cancers can also cause fistulas as a late complication. Even a simple rectal abscess near the vagina can sometimes burst through, creating a fistula.
Repairing these sounds challenging. Is bowel prep essential again?
Absolutely essential. You need a meticulous bowel preparation with antibiotics like fethizole, neomycin, ampicillin, and mechanical cleansing, plus vaginal disinfection to minimize the bacterial load and give the repair the best chance of healing without infection.
What's the basic surgical principle for repairing a straightforward low fistula?
For a low fistula near the perineum, the standard approach is often to surgically convert the fistula into a complete perineal tear. Basically, you cut down through the tissue bridge between the fistula opening and the anus, laying the whole tract open. This gives you good exposure.
And then you repair it like a fresh tear.
Exactly. You then repair it in layers, just like repairing a primary fourth-degree tear, closing the rectal mucosa carefully, reconstructing the sphincter muscles and perineal body, and closing the vaginal mucosa and skin.
What about higher fistulas, or those caused by cancer or radiation?
Those are much more complex. High fistulas often require an abdominal approach, sometimes with bowel resection. Fistulas due to active cancer or severe radiation damage are extremely difficult to close successfully and may require a permanent diverting colostomy, or in very select cancer cases, a massive operation called pelvic exenteration. Hashtag outro.
Wow, that was an incredibly detailed exploration. We've covered a huge amount, from subtle obstetric changes to catastrophic ruptures and complex repairs, really highlighting that intricate link between the genital and intestinal tracts.
It really underscores how central obstetrics is to so many of these high morbidity injuries. Synthesizing the key points from our sources, there are a few things that really stand out, challenging maybe some standard assumptions.
Like the occult injuries, that 35% statistic is hard to forget. It suggests just looking isn't enough after delivery.
Exactly. It really pushes us to reconsider routine postpartum assessment and follow-up. Maybe we need more widespread use of tools like endoanal ultrasound, or at least much more proactive questioning about subtle symptoms.
And the risks outside of childbirth, too. The potential severity of coital trauma after hysterectomy, or that delayed presentation of thermal bowel injuries after laparoscopy. Those are critical diagnostic traps.
Definitely. And thinking about the body's adaptations, that compensatory levator hypertrophy in women with old unrepaired tears is fascinating. It explains the lack of prolapse, but highlights their ongoing struggle for continence.
And finally, the repair itself. Success hinges on immediate diagnosis of severe tears and that meticulous layered anatomical reconstruction. Whether you prefer end-to-end or overlap for the sphincter, getting the anatomy right without tension seems paramount. So we've seen how vital timely intervention and precise surgery are for preventing lifelong problems. It makes you think, though. If we know occult sphincter injuries are so common and often only cause obvious incontinence years later, how could we better integrate those non-surgical approaches? The intensive physiotherapy, the biofeedback training we mentioned. Could they become a standard, universal part of postpartum care to proactively strengthen those potentially injured muscles before they fail, maybe preventing the need for complex surgery down the line?
That's the million-dollar question, isn't it? Shifting the focus from late, complex repair towards early detection, prevention, and functional rehabilitation. That could potentially improve the quality of life for countless women, a critical challenge for the future.